afternoon, everybody. I'm Lisa Napolitano, the founder and president of the Florida Cognitive Behavioral Therapy Association. And on behalf of the board of FLCBT, I want to welcome you to this professional training webinar. For those of you who don't already know, FLCBT is a nonprofit organization designed to disseminate CBT in Florida and promote community among CBT providers in Florida. Today's webinar is part of an ongoing series we're offering over the course of the year with topics ranging from the Unified Treatment Protocol to acceptance and commitment therapy and emotion regulation therapy. So please check out our website for upcoming events and for information on how to become a member at floridacbt.org. Today, I'm delighted to introduce Julie Featherman, an FLCBT board member and counselor with nearly 2 decades of multidisciplinary experience spanning higher education, online learning, marketing, and business operations. After earning her Master of Arts in Clinical Mental Health Counseling from Virginia Tech, Julie transitioned into mental health work, providing support in a residential crisis stabilization unit and in a nonprofit setting offering individual, couples, and group therapy. Julie founded her fully virtual practice, Featherman Therapy, in 2020. She works with adults struggling with anxiety, depression, ADHD, family and relationship issues, career challenges, and other phase of life concerns. Julie has done extensive training to support clients with OCD, having completed the Behavior Therapy Training Institute through the International OCD Foundation. And more recently, she's been trained to deliver inference-based CBT. However, Julie's clinical specialty and passion is working with bodily focused repetitive behaviors, such as trichotillomania and dermatillomania. Julie has completed extensive training on the comprehensive behavioral treatment model and has supported many individual clients who have struggled with these often misunderstood disorders. Julie is based in Aventura, Florida, and is licensed to practice in Florida, Virginia, District of Columbia, Pennsylvania, Ohio, and Georgia. So Julie, without further ado, I turn it over to you.
Wonderful. Thank you so much, Lisa. Good afternoon, everybody. Thank you all for joining. So let's begin. Jumped ahead. I want you to all consider the following questions. How many of you have ever either bit your nails or maybe trimmed a stray cuticle? Have you ever pulled out that first gray hair or maybe plucked an errant eyebrow? Have any of you ever picked at a scab or maybe popped a zit? How about chewing on your lip or the inside of your mouth? And last but certainly not least, how many of you have maybe been known to pick your nose? I'm guessing that you all answered yes to at least one of those questions, as many people engage in these body-focused behaviors at some point in our lives. For most of us, we're able to either pick or pull and then go on our way. But for some, it becomes much more challenging to stop the behavior once it's begun, which leads us to today's topic, which is body-focused repetitive behaviors. All right. So what is a BFRB? First, BFRBs have only been diagnosed as disorders in recent decades, but the acknowledgement of these behaviors extends much, much further back. The first written mention of the behaviors was by Aristotle in 340 BC, when he referenced the habit of plucking out hair and gnawing on his nails in one of his works. The first documentation of the behaviors in medical literature was made by Hippocrates, when he referenced the effects of stress on the skin and described cases of hair pulling behavior caused by stress. In 1875, Erasmus Wilson coined the term neurotic excoriation to describe difficult to control skin picking behavior. And in 1889, a French dermatologist first used the term trichotillomania to describe hair pulling behavior. This behavior was also described in literary works, including the Old Testament of the Bible and by Shakespeare and Romeo and Juliet. From a diagnostic perspective, trichotillomania first appeared in the DSM-3, the revised edition, in 1987. It wasn't until the DSM-5 that excoriation or skin picking disorder first made an appearance. So although these have been around for a long time, they're relatively new diagnoses. So what are these behaviors? Body-focused repetitive behavior is a general term for a group of related disorders that includes things such as hair pulling, skin picking, nail biting, and other body-focused behaviors. These behaviors are not habits or tics, but instead they are complex disorders that cause people to repeatedly touch their hair and their body in ways that result in physical damage. The difference between the normal grooming behaviors that I initially asked you about and a BFRB arises when there's been repeated attempts to decrease or stop the behavior, and when the behavior causes substantial personal distress and or interferes with daily functioning. All right. So what are some of the more common BFRBs? This is a list of a lot of them. So as you can imagine, any behavior that's body focused, repetitive, unwanted, and causes damage or distress is likely classified as a BFRB. Common ones are shown on the slide and include trichotillomania or hair pulling, excoriation disorder or skin picking, nail biting, nail picking, chronic manicuring, trichophagia, which is eating of the hair, eating of the skin, cheek biting, lip biting, tongue biting, cutting off of one's hair, such as compulsively trimming split ends, and nose picking. And you'll notice I didn't try to attempt to pronounce a lot of those because they're tough words. So individuals who struggle with trichotillomania, typically pull out their hair from lots of different parts of their body. Most common are the scalp, the eyelashes, eyebrows, and the pubic hair. Oftentimes results in noticeable bald patches. About 5 to 20% of people who pull their hair out also swallow their hair, or trichophagia. Typically, the ingested hair remains asymptomatic and is not harmful. However, if trichophagia is severe or chronic, a large mass of undigested hair can accumulate in the stomach, and that results in a trichobezoar. This can be symptomatic and includes things such as nausea, vomiting, and abdominal pain. And once the trichobezoar grows large enough, it can extend beyond the stomach and can lead to bowel obstructions, ulcers, perforations, acute pancreatitis, and appendicitis. And I'm making a mention of this because if you do end up working with clients who do pull their hair, it will be important to assess for trichophagia because it can be a very serious medical concern. Skin picking, of course, is when the focus is on the skin. In this case, individuals may repetitively touch, rub, scratch, pick at, or dig into their skin, resulting in skin discoloration, scarring, and even severe tissue damage and disfigurement. Many of us are likely familiar with nail biting and may have not even realized that this is a BFRB. This disorder can cause people to bite their nails past the nail bed and chew on cuticles until they bleed, leading to soreness and infection. And again, there's an additional laundry list of BFRBs. So to get a little bit more technical, let's take a quick look at the diagnostic criteria for some of the BFRBs. So, as previously mentioned, trichotillomania has been in the DSM since the DSM-3. The diagnostic criteria that separates these typical grooming activities from their more complicated counterparts include things such as, sorry, I lost trichotillomania first appeared in the DSM-3, and in the DSM-4, was classified as an impulse control disorder, along with things such as kleptomania and pyromania. It didn't quite fit with those. So with the introduction of the obsessive compulsive and related disorders category in the DSM-5, trichotillomania was reclassified, and some of the criteria were slightly modified, specifically related to the individual's experience just before and following pulling the hair. The current criteria are, recurrent pulling out of one's hair resulting in hair loss, repeated attempts to decrease or stop the behavior. The behavior causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. The hair pulling or hair loss is not attributable to another medical condition, such as a dermatological condition, and it's not better explained by symptoms of another mental health disorder. The diagnostic criteria for excoriation is quite similar. Instead of focusing on hair pulling, of course, it focuses on skin picking, recurrent skin picking resulting in skin lesions, repeated attempts to decrease or stop the picking. The picking causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. The picking is not attributable to the physiological effects of a substance such as cocaine or another medical condition such as scabies. The picking is not better explained by symptoms of another mental disorder, such as delusions or tactile hallucinations that appear in a psychotic disorder, attempts to improve a perceived defect or flaw, such as in body dysmorphic disorder, stereotypy, such as in stereotypic movement disorder, or the intention to harm oneself. And then finally, we have other specified obsessive compulsive, sorry, my mouse is very sensitive. Other specified obsessive compulsive and related disorders. So these are new in the DSM-5, along with excoriation disorder. They appear under the other specified obsessive compulsive and related disorders with a designation of body focused repetitive behavior disorder. So they're sort of tucked away in a corner. But again, very similar criteria: recurrent behavior, repeated attempts to stop or decrease, causes clinically significant distress or impairment, and it's not better explained by trichotillomania, excoriation, tics, or non-suicidal self-injury. So that's, diagnostically what we're dealing with. So who typically develops a BFRB? Now that we have a better sense of what a BFRB is, let's discuss who typically develops a BFRB. It's estimated that about 2% of the general public, or about 1 in 50 people, struggle with hair pulling, and approximately 2 to 5% with skin picking. While there have been far fewer studies on other BFRBs, those published have indicated that they're also pretty common, with 20 to 30% engaging in nail biting and about 3 to 6% reporting mouth, lip, or cheek biting. BFRBs typically begin between the ages of 11 and 15, with the onset of hair pulling generally being a little bit on the earlier end of that, such around 11 or 12, while skin picking typically begins a little bit later, around 14 or 15. Very young children, ages, like newborn to 6, may experience something that we call baby trick. This is usually a temporary condition, and it looks different than the chronic condition that older children and adults may experience. Kids that experience baby trick usually grow out of it. Chronic nail conditions are really underrecognized, and as such, people rarely seek out treatment to decrease the behaviors. We think that about 45% of people may actually engage in these behaviors as children, and then those numbers drop off to that 20 or 30%, as they get into adulthood. And then finally, among adult hair pullers, females have historically outnumbered males 9 to 1. though when the hair pulling begins in childhood, the ratio is roughly equal. There could be a lot of different reasons for that. Hormones, more focus on women's hair just in general, but that's the typical division that we've seen. All right. So what causes BFRBs? So as far as what causes them, we're still figuring that out. BFRBs are really poorly understood. They're underdiagnosed and untreated group of mental health disorders. What we do know is that research has shown that some people may have an inherited predisposition for skin picking or hair pulling, with several studies indicating a higher number of BFRBs in immediate family members of people with skin picking or hair pulling than would be expected in the general population. Even if a predisposition towards BFRBs is inherited, there are other factors involved that may include temperament, environment, age of onset, and different stress factors. Research suggests that BFRBs may include improving or correcting an imperfection in physical appearance, in addition to self-regulation of intense emotions. Of sort of interest, hair pulling and skin picking is not only seen in humans, but it can also be seen in other species, such as primates, who pick at nits and other insects on their own fur and the fur of others. Birds who are stressed will pull out their feathers. Animal researchers are trying to understand these similar appearing behaviors in animals to shed light on some of the complex neurobiology that underlies the human experience of BFRBs. All right. So how does one experience a BFRB? There are both internal and external or contextual antecedents that precede the behavior. There may be thoughts that come up either about the behavior or about things unrelated to the behavior. People may think to themselves, I'm going to give myself permission to engage in this, or they may think that they have no ability to control the behavior. There may be images that come up prior to the behavior, or memories. For many people, there are emotions that precede the behavior. Some particular emotions are anxiety, boredom, indecisiveness, tension, fatigue, sadness, shame, guilt, anger, excitement, frustration. So many emotions that we all feel. And then sensations or urges. Some bodily sensations may occur. I've heard individuals talk about feeling like a tingling in their fingers or in their scalp. There are other bodily sensations or urges that may precede the behavior. There are also both external and contextual antecedents. So there's movement and automaticity. So that includes movements, body postures, and activities. In what ways does a person's body more easily facilitate a BFRB? I worked with one client who every single time they got into the car to drive somewhere, their hand immediately went to their head. Are there particular postures or body movements that make it more accessible? Do people touch or physically search for a target? These are all things that may precede the behavior. The level of awareness of, what you're doing, or if you're on autopilot. There's also vulnerabilities that may precede the behavior. There are biological influences such as genetics, some co-occurring conditions, sleep, nutrition, and exercise that may make someone more susceptible to engaging in the behaviors. So, for individuals to understand what some of these antecedents may be for them. Is there a genetic predisposition? Is there an underlying medical condition? Do they maybe have ADHD or another co-occurring mental health condition? Do they notice if there are changes related to their sleep, their nutrition, their substance use, their hormones? All of these are things that may precede the behavior. And then finally, people, places, and spaces. So where you are and who and what is around you. Are there particular times of day that may be more of a trigger than others? I've worked with a number of clients who are usually pretty good in the morning. As the day progresses, it becomes harder to resist the behaviors. Um, are you with others or are you alone? Many people will not engage in the behaviors in front of other people. Um, are there specific people around you? Are there implements around you? Do you have access to tweezers? Um, is there a mirror nearby? Um, are there specific activities that may, be more of a trigger than others? So those are all the things that precede the behavior. Lots to consider. Then there's the actual behavior itself. So that includes both searching. So, the individual may either with an awareness or with a lack of awareness be searching for a specific piece of hair, skin, or nail. It's usually a habitual process. It may begin with a visual examination or more of a tactile, touching the area to feel for a particular characteristic. There's the action. There's actually doing the behavior, um, pulling the hair out, picking at the skin, biting the nails, chewing on the cheek, inside of the cheek, you name it, the behavior happens. And then the disposition. So typically there's some sort of product, whether it be, you know, a piece of cuticle skin or a scab or a piece of hair. And people do different things with the product. For some, they may just toss it aside. With a piece of hair, they may pop the root off the end of the hair. They may rub it on their lips. I had one client who would, the root of the hair is a little bit sticky. And so she would sort of put it on her mirror, almost as a reminder of like, this is what I've done. Like, these are the hairs I've pulled. Um, as people are engaging them in the behavior, as we talk about treatment, we'll ask them to notice both, what's happening internally and externally as they're doing the behavior, not only, both before and then as they're actually doing the behavior. And then finally, the consequences. These consequences can be really complex and self-reinforcing. So for someone, the initial consequence may be a feeling of satisfaction. Like, I got that hair. I was able to, get that hangnail that's been bothering me. That satisfaction may quickly move to discouragement or shame or disgust or some other emotion. Um, and so the consequence, often changes over time. And, it will be important for individuals to be noticing what's happening, internally and externally as they deal with the consequences of their behavior. All right. So, so we've engaged in the behavior. What are some of the physical effects? So the physical effects are really wide ranging. They can be as minor as some itching or, maybe a little bit of exposed skin. Um, there could be, repetitive motion injuries. There could be tissue damage, scabbing, open wounds. As we talked about with trichophagia, there may be stomach or intestinal problems. For individuals who bite their cheeks, there may be lesions or ulcers on the inside of their mouth. For those who chew on their tongue, there may be thickened skin or changes in pigmentation. For nail biting, damage to cuticles and nails, risk of bacterial or viral infection, obviously, damage done to the nails, but then there's also the risk with nail biting of mouth and jaw problems because you're typically using your mouth and jaw to bite your nails. So there could be injury to the soft tissue lining of the mouth, um, dental problems, disorders of the jaw, bone infection. Um, you know, again, these physical effects can be really wide ranging. I've heard stories of people who've ended up, with chronic, um, you know, like movement conditions, it ended up at physical therapy or at the chiropractor because of repetitive motion injuries. Um, there's and you'll see that if you go to the Picking Me website, which is an organization specifically focused on skin picking. The founder of that organization talks about how she actually almost lost a leg to MRSA due to infection that she um, got from her skin picking. I worked with someone once who was tweezing their eyelashes, like tiny little nubs of eyelashes, and almost slipped. And she didn't, but she almost stabbed herself in the eye with her tweezers. So there's a wide range of potentially really dangerous physical effects. Um, but, in some ways, even harder than those physical effects, are the emotional effects. So we lead with the positive emotional effects because this is part of what maintains the behavior is that for some they can be pleasurable. It can provide some relief. It feels good for some. It can decrease boredom, but there's a wide range of negative effects that in some cases far outweigh the positive. Emotions such as anger, anxiety, shame, sadness, frustration, decreased levels of calmness, uh, lower self-esteem, feelings of being unattractive. It strains people's relationships. It can cause, levels of depression. There's a lot of secrecy involved with the behavior. People may become emotionally reactive or dysregulated, um, as a result of the behavior, or that may be something that the behavior may be something they use to regulate themselves. Um, Diminished quality of life, increased distress. I want to pay a special attention to the last two listed. So, one of the effects is an increased desire to camouflage or cover affected areas. And this is an interesting one because it is both an effect of the BFRB, but can also be a strategy to use to manage the behavior. Things such as, wigs, hats, scarves, headbands, various hair products and hairstyles, makeup, band-aids, false eyelashes, acrylic nails, clothing that covers, and some people go as far as even shaving their heads. Um, you know, Although it's for many, it may be frustrating to have to wear a wig or to have to wear a hat, or to have to put band-aids over, scabs and scars. Those can also serve as barriers. They can help at least temporarily provide a way to make it harder to engage in the behavior. And then finally, avoidance behaviors. So people will avoid things that we don't even think about. They'll avoid being in bright light. They'll avoid windy situations because they don't want their hair blown around. Um, they'll avoid water. So going to the beach, going to the pool, being out in rain. This could, expose bald spots on their head. It could wash off makeup. Um, they'll avoid medical care. There are individuals who will avoid going to the dermatologist because they don't want the dermatologist to ask them about all of the scabs and scars on their body. Individuals who will avoid the dentist if they've got, you know, raw skin on the inside from, chewing on their cheek or their tongue. People avoid hair salons. They'll avoid getting their nails done. Um, but then they also avoid even bigger things. They'll avoid going on vacation. They'll avoid, job duties. They will stop going to school. They'll stop studying. They'll avoid social events and group activities. A lot of times that sort of links into the low self-esteem, the feelings of being unattractive. Um, some of this is they're actively choosing not to do these things, and some of this is actually time lost to engaging in the behavior. Um, I've worked with clients who will pick until, wee hours of the morning and then sleep through responsibilities because they've been up all night, picking or pulling. So significant number of effects, both, physical and emotional. All right. So I've referenced this a little bit, but BFRBs rarely exist in a vacuum. Oh, sorry, jumped ahead. This is very sensitive today. Um, they rarely exist in a vacuum. Oftentimes, they exist with other mental health disorders. Some of the common ones are anxiety, depression, OCD, ADHD, PTSD, panic disorder, bipolar disorder, substance use disorder, eating disorders, and tic disorder. Anxiety and depression in particular, there's a little bit of a chicken egg thing, as the anxiety and depression can be both an antecedent or a consequence of the behavior, or unrelated. Um, Many people with BFRBs do report that at least some of the time when they're engaging in the behavior, they're feeling anxious or stressed, but there are also, other emotions, sensations, et cetera, that can trigger the behavior. For those with ADHD, some of the fidgeting and impulsivity that comes along with that disorder can manifest as body focused repetitive behaviors. Um, and as we'll talk about, on the next slide, although BFRBs and OCD are different things, there are some individuals who struggle with the just right subtype of OCD who are more prone to engage in skin picking and hair pulling, that, in the search for their skin and hair to be just right. All right, so we'll move on to some common questions and answers. So are these OCD? They are not. Although individuals with BFRBs do engage in repetitive, seemingly compulsive behaviors, there are enough differences between BFRBs and OCD to suggest they're different disorders. Do BFRBs mean that there's some sort of deeper problem? Are they caused by trauma? Um, some people assume that hair pulling or skin picking is a sign of some unresolved issue or problem that needs to be addressed for the BFRB to get better. Current evidence suggests, however, that these behaviors are not generally an indication of deeper issues or unresolved trauma. Now, that's not to say, someone could have trauma and also a BFRB, but they're rarely, related to each other. Are hair pulling and skin picking a form of self-harm? Those who engage in these behaviors do so either to relieve stress or to experience, gratification or some other sensation. This is typically in contrast to those who self-harm, who are intentionally harming, punishing, or attempting to distract themselves from intolerable emotions. Thus, they don't appear to be a form of self-harm, but rather, again, separate and distinct. Are BFRBs just bad habits, and can they be stopped with enough willpower and punishment? If that was the case, I'd be out of a job. No, these are complex disorders and they require very skilled intervention. No amount of willpower alone is likely to be sufficient to effectively stop the behavior. That said, I've seen clients who have willpowered their way into periods of time where they stopped the behavior, but it always comes back. Again, and in addition, punishment does not help at all to decrease the behavior, and actually has the potential to intensify the shame and guilt that individuals with BFRBs often experience. Are people always aware of their BFRB? Not always. They can occur with little or no awareness. Some individuals experience both focused and unfocused. In some cases, it may start off unfocused and then become more focused. The unfocused behaviors typically occur when people are doing other things, such as reading, doing work at home, watching TV. How are BFRBs diagnosed? Well, this is part of why you're all here today, to learn more about them. BFRBs are diagnosed by a clinical interview with an informed healthcare professional. They may also administer some questionnaires to further assess symptoms. In some rare cases, a scalp biopsy may be used to rule out alopecia when the hair pulling is either denied or is occurring outside of an individual's awareness, but there's no medical test to diagnose a BFRB. All right, so how do we treat them? This is the big question. So we'll start with medications. There's not any there's currently no FDA-approved medication for the treatment of BFRBs. There are some meds that are sometimes used. Most commonly are SSRIs, and this is in part due to the evidence for their use in treating OCD. Um, However, research shows that they don't effectively treat BFRBs. Um, SSRIs, however, can be useful in treating some of the co-occurring symptoms that may impact or maintain BFRB symptoms, so that underlying anxiety or depression. There's an amino acid called N-acetylcysteine or NAC that has been shown to help control hair pulling for about half of the participants that were in the study where this was tested. This, however, only seems to have worked for adult participants, and there's no evidence that this amino acid works for children who struggle with the behavior. In some cases, skin medications may be prescribed both to deal with some of the antecedents and also some of the consequences of the behavior. So for some who have underlying acne or other dermatological issues, eczema, those sorts of things, they may be prescribed medication to reduce the symptoms of those dermatological conditions, which will then, in theory, decrease some of the behaviors. There's also medications that are prescribed after the fact to promote healing of the skin after skin picking's been done. All right, so then we've got habit reversal training. This was sort of the first treatment that was introduced for BFRBs. It is a simple behavioral intervention that aims to change the pattern of behavior through new behavioral practices. The course of treatment includes psychoeducation and a functional analysis of the behavior, awareness training, competing response training, and stimulus control. The second and probably most popular, most widely used treatment is the comprehensive behavioral treatment, or COMB. This is a broader, individualized, flexible cognitive behavioral approach that's based on factors that both cue and maintain BFRBs. This is the most widely used treatment and has been the dominant model of clinical training. As Lisa mentioned when she introduced me, this is what I've been trained in. This includes an assessment and functional analysis. It focuses on 5 domains. Those domains are sensory, cognitive, affective, motor, and place. Then the identification and selection of target domains happens, and then an implementation of the specific interventions based on those domains, and finally evaluation, termination, and relapse prevention. Some of the more recent introductions into treatment are ACT-enhanced behavioral therapy. This combines principles of ACT, such as understanding clients' values, understanding how clients may relate to urges and negative experiences, seeing internal experiences for what they are, and commitment to the process. And it combines all of those with habit reversal training and stimulus control. It focuses on experiential avoidance of unwanted thoughts, feelings, and bodily sensations associated with BFRBs, and it seeks to improve psychological flexibility. There are also some who will use DBT, or dialectical behavioral therapy, as an adjunct to habit reversal training. In this case, they will focus on skills training to improve emotional regulation, distress tolerance, and the impulsivity that may be associated with BFRBs. There are technology-assisted treatments that have come up in recent years. These include the internet, application-based or device-delivered interventions to improve access and treatment outcomes. There's a lot of promise with technology, as their use may decrease barriers to treatment and may guide the practice of skills in the individual's natural environment. However, some research has shown that there is a preference for face-to-face interaction with treatment, and there are some concerns about confidentiality and security with these treatments. One of the newest treatments in the game is an integrative behavior therapy. And for this, the goal is to improve quality of life by changing one's relationship to their BFRB experiences and to broaden tools to more effectively manage them. This is a unified protocol that includes a functional analysis. It integrates essential theoretical and treatment elements of habit reversal training, COMB, ACT, DBT, and the trans theoretical model of change. All right. So what is the prognosis? Sorry. So I typically, and my clients don't usually like this, but I typically tell clients when they come in to see me that if their goal is to stop picking or pulling, they will likely fail. Um, Treatment's a process. Once a BFRB is developed, it's important to be aware that it's possible and usually pretty likely that it will reoccur even after a significant period of remission. Um, Effective maintenance includes accepting that lapses happen and that there's a willingness to re-engage in problem solving and reinstate the use of techniques that have been successful in the past. There's an assumption of a non-judgmental perspective in which the likelihood that the BFRB or urge may come back from time to time is both acknowledged and accepted. There needs to be a willingness to contact a therapist or other appropriate supports when necessary. And when the individual is able to acknowledge the possibility of a slip and is willing to use appropriate and effective resources, maintenance can be quite successful and manageable. And then finally, before we get to our question and answer period, we've got some helpful websites. So first is the TLC Foundation for Body Focused Repetitive Behaviors. This organization has been around since 1991. It was originally called the Trichotillomania Learning Center, which is where the TLC comes from. This is the OG group, and it focuses on things such as advocacy, awareness, connection, health education, celebration, and equitable access to effective evidence-based treatments. They typically have an annual conference, in which case a number of the different researchers and big players in the BFRB field go and report on research they've done and other things. I've been to the conference 6 or 7 times. It's a fabulous conference for those who are interested in learning a bit more. BFRB Changemakers is a newer organization. This group sponsors some peer-led support groups and professional trainings. They also collaborate with other US-based and international BFRB advocacy nonprofits and charities to support and amplify community healing. They have a link on their website to a number of these other organizations. It includes, international groups, groups for Spanish speakers, the group I mentioned earlier that's specifically for skin picking, a group that's specifically for people of color. So they really are serving as, a group to pull together all of the different corners of the world that are addressing BFRBs. And then finally, Habit Aware. So you may be familiar with the Habit Aware bracelet, the Keen 2. That's the technology assisted device I was referring to. It can be trained to, based on different hand movements, to buzz when you go to pull a hair or pick at your skin. Along with selling that device, their website also provides access to courses and coaching to supplement the technology. So, 3 really great resources if you want to learn more, maybe look into getting a training. And that is everything. So I'm going to pause and take a sip of water and open the floor to questions.
Hi.
Yep. Hi, how are you, Alicia?
I just wanted to say thank you so much. That was wonderful. Since I've known you, I've looked forward to having you educate me on this. So thank you very much.
Yeah, you're welcome. And I know I went really fast. And if you want to follow up with anything, feel free to.
I will. Absolutely. Thanks so much, Julie.
Yeah, absolutely. I'm curious, as you all think of questions to ask, have any of you worked with clients with BFRBs? And what's that experience been like?
I had a DBT client with who has BPD with a skin picking disorder, and it was just a lower priority item because we were dealing with so many
Mhm.
other issues. But I wish I had a little bit more training just to kind of help facilitate, because I know it caused a lot of shame, and the shame was a vulnerability then acting on much higher priority items.
Yeah.
So I look forward to like getting HRT training, like DBT HRT.
Yeah.
I've had a similar experience just working with folks where it was kind of more secondary. We ended up working on it and kind of things got to a place where they felt like they were managing it better. And then they just kind of on their own felt like where it's at right now is kind of good for me and wanted to focus on other concerns. And I specialize in anxiety and OCD. So like folks were working on those things. And then every now and then I just kind of, check in on like, okay, like how is it going with, skin picking? And does it still feel like something you're managing okay and want to leave on the back burner? And I don't know if you have any feedback on that. Like if the patient is saying like, yeah, it still happens and it's still something that, sometimes at night, like when I'm talking on the phone, I notice I'll do
Mhm.
that, but like it's not like they're not describing it as something that is highly distressing or interfering in functioning then.
Yeah. Yeah. And I think that's one of the things that I really like about this newer integrated model is that there's this focus on stages of change and assessing, how motivated is the client to actually address it? Is it causing an issue or is it just something that's there in the background that, maybe it rises to higher concern later on, but I think just always assessing where they're at in terms of wanting to address it.
Yeah, I was just going to say, I worked with someone who had pulled out all her eyelashes in adolescent, and she was avoiding swimming and she was wearing very big
Yeah.
glasses, camouflage.
Yeah.
And it was very helpful to take photos as we went through treatment. It was very
Mhm.
reinforcing for her to see the incremental progress. But what was another thing that was interesting, and I'm glad you touched on this, the emotion regulation function of the behavior. And
Yeah.
I was using Nancy Puthen's protocol, HRT, which she expanded to incorporate some of the DBT skills. She would typically pull when she was bored. So it functioned
Mhm.
through boredom. Um, but she also enjoyed the sensation
Yeah.
of removing the hair. So it was both
Yeah.
positively and negatively reinforced. Yeah.
Yeah. And that's so common. And that's part of what makes these so complicated to address because, there's some compelling feature to them that, makes people want to do them.
Yeah, which is so important in terms of the competing response, right?
Exactly. Yeah,
Mechanism. Yeah.
exactly. Oh, I see someone's hand is raised.
Yeah.
Hello, Julie. Thank you very much
Hi.
for the session. Really
Yeah,
useful. Like it a
absolutely.
lot. And I have a doubt. Is it advised to use like another object in the transition to make it conscious? Like instead of using the hair, like it's not solving the regulation problem, like the emotion
Right.
problem, but in the transition to make it conscious, to use another object like I don't know the plastics with bubbles that someone used, and instead of doing the hair using the bubbles, is it like
Yeah.
advised?
Yeah, I mean, and part of the functional analysis is to figure out, what's driving the behavior. And, if it's a matter of that they're just sort of need something to do with their hands, if they're, seeking like some sort of like fidget sensation, then something, like what you described could absolutely work. But again, it really depends on is what those antecedents are, what's driving the behavior. And I've had a lot of clients who have come to me and said, and this is no knock at all on people who don't have the training because they don't know, but clients have said, that the therapist just handed me a fidget and like that wasn't enough. And so really, better understanding what's underlying and what's causing the behavior. I mean, a fidget's never a typically not a bad thing, but it's rarely going to solve the problem.
Thank you, Julie.
Yeah, absolutely.
I
Go
was
ahead.
just going to ask you if they've done any studies on the comparative efficacy of the different approaches.
Not to my knowledge.
Okay.
That would be a really good research study for someone to take on.
Yeah.
So yeah, that's not to my knowledge. That hasn't happened. Yeah, I like that idea.
Yeah, because I know ACT has some data. I think that's Doug Tuhig and colleagues who did their protocol. And I know Nancy Kuthin has some data on her approach, but it'd be interesting to compare
Yeah.
them.
Yeah, and I'm sure that Charlie Mansueto and
Yeah.
that they have loads of data on Cone B. Yeah, that's a really interesting idea. So what I was going to mention, which I didn't really get into too much in the presentation, is, and this is something for those of you who work with kids that you may see. I only work with adults, sort of by design, because oftentimes with the children, the kids are totally okay with the behavior, and it's the parents that want them to change. And that can be really, really difficult to manage. And, I think that that's probably true of a lot of behaviors, but it seems like this behavior in particular can be really distressing for parents in ways that it's not necessarily distressing for the kids. And so I think I don't know that there's been a lot of focus on, really an educational component for the parents, but I think that's a hugely important piece of treating kids with BFRBs.
I was just going to ask Julie, there's these different kind of monitor things, right? Of like, you put it on your wrist and then it's going to notice when you do that movement and it's going to buzz you and alert you. What's the data? Like, is there data behind that to support that that's something? Because, right, so often, at least in my experience, when BFRBs are an issue, one of the main things is like, oh, like these are great strategies, but in the moment, I just don't even realize that I'm doing it. And then it's like, by the time I notice, it's so.
Yeah. I believe that there is data on that. I think, if I'm remembering correctly, there was an NIMH grant like a couple of years ago to study the efficacy of those devices. I don't know the results off the top of my head, but I do think that there is data that exists on that. So I can see if I can get that and share it with you.
Thanks again, Julie. Really appreciate this. It was great.
Yeah, no problem. Absolutely no problem.
Well, if there are no further questions, thanks everybody.
Bye, everyone.
Have a great
Yeah, thank you all for coming. This was wonderful. Thank you.
Thanks, Julie.
Take care.